Hello, everyone, and welcome to the UVA Medical Center Hour. I'm Justin Mutter, Director of the Medical Center Hour, which is a program of UVA's Center for Health Humanities and Ethics. We're delighted to offer today's event in partnership with UVA's Generalist Scholars Program in celebration of National Primary Care Week, which is a time when we pause to reflect on the importance of primary care to the public good. As is always the case for Medical Center Hour, continuing education credit can be claimed for your participation in today's event. We invite you to follow the directions that will appear on slides at the end of the event in order to claim your credit. Today's event is in Zoom-only webinar format, and so if you have questions to be considered at the discussion time of today's event, please enter those on the Q&A tab on the bottom of your Zoom screen. In 1978, emissaries from all over the world met in a region of what is now Kazakhstan to issue a major statement on the importance of primary care to the communities of local, regional, and national and international importance. The Declaration of Alma-Ata, as it came to be known, re-emphasized the World Health Organization's original conception that, quote, health is a state of complete physical, mental, and social well-being. The declaration went on to situate primary care at the epicenter of that commitment, stating that primary care must not only be, quote, the central function and main focus of all nations' health systems, but also an essential component of the, quote, overall social and economic development of all communities. These are certainly strong words, worth hearing again and again in today's world. But how in our current moment can we live up to this declaration? If primary care functions best where the medical meets the social, how can we make this meeting a true and effective symbiosis? Today, it's our privilege to welcome Dr. Emilia De Marchis, a leading thinker and practitioner in the effort to make the Declaration of Alma-Ata a reality in the United States. Dr. De Marchis is a family physician and health services researcher at the University of California, San Francisco, where she is affiliate faculty of the UCSF Social Intervention Research and Evaluation Network, or SIREN for short, about which we'll hear a little bit in the time to come, where she works to assess and improve how we screen for and respond to patient social risk factors within healthcare settings. An expert in implementation science, Dr. De Marchis is involved in a host of efforts utilizing implementation science to move research on social risk screening into real-world settings. Through her research and clinical practice, she hopes to advance the healthcare system's integration of these social risk information factors to provide high-quality, person-centered preventive healthcare to reduce health disparities. Emilia, welcome to today's Medical Center Hour stage.
Thank you so much for having me. It's great to be here, and thank you for that kind introduction. Can everyone see my slides? I guess it doesn't. Okay. Wonderful. Well, as Dr. Mutter mentioned, I am an assistant professor of family community medicine at the University of California, San Francisco, and my research is based out of the SIREN, the Social Interventions Research Evaluation Network. And I'm actually 50-50 clinical and then research and teaching, and I teach through the UCSF Partnerships for Research and Implementation Science for Equity, or PRIZE Center, and also co-chair the UCSF Health Social Drivers of Health Task Force. And with that, I will be talking today about integrating medical and social care in primary care. I have no disclosures. I do want to just acknowledge past and current funders of the research I've led or collaborated on. As a brief introduction for those who may not be familiar, at my affiliated research group, SIREN, our goal is to really advance the current research efforts around social and medical care integration to improve equity and help ensure that research in this area gets translated into practice and help promote the sharing of best practices and evidence to those working on the ground. I still show this slide, but recognize that this is now fairly well acknowledged that healthcare is really only a small part of determining a person's health. And we know that social and environmental factors or behaviors often influenced by the social and environmental factors contribute much more to a patient's health than the healthcare they receive. In today's talk, I'll take a moment to review some of the terminology when talking about social care because it can get quite confusing. I'll review also some of the policy context in which this work is occurring. I'll review a framework for thinking about social care, discuss some of the emerging best practices for social care integration, and then take a moment to spotlight a few practice innovations around social care delivery. So on to terminology. We've all likely heard a lot about social determinants and now a push to call the social drivers of health, trying to move away from more of a deterministic framework, which is why there's a push for social drivers versus social determinants. You also have likely heard the words around social risk factors or social needs or health-related social needs, lots of different terms. So when we talk about the social determinants or drivers of health, as you all likely are familiar, these can both positively or negatively impact health. So if you just say a social determinant or social driver, take education, having higher educational attainment is associated with positive health outcomes versus lower educational attainment is associated with negative health impacts. So we like to often refer to social risks when we're talking about the adverse social conditions that someone is exposed to, which is often the way people use social determinants commonly, but just to be very clear when we're actually talking about those adverse social conditions, so the lower educational attainment, housing instability. And then social needs we use when we're trying to take more of a patient or family-centered perspective. So these are the risks might be something that we screen for, might be identifying through screening, but it doesn't necessarily mean that the patient sees it as a need or something that they think that they need assistance with or want assistance with. And then when we think about the activities that surround screening for and responding to patient social risk factors, we refer to those as social care activities more broadly. And these other terms have also been used, social prescribing, especially actually in the UK, not as much in the US. And then I'm just going to briefly go over two kind of those responses to identified social risks, and we'll talk more about this later on in the talk. But there's social risk targeted care, which is assistance, and this is what we most commonly think of as a response to screening or identifying a risk. So the actual trying to address that risk factor. So this might be connecting a patient with food insecurity, identified food insecurity, to a food pantry, or someone who's experiencing transportation barriers, transportation vouchers. And this is opposed to social risk informed care or adjustment, which is how we actually in the medical world might take into account a patient's social situation when providing medical care and use shared decision-making to make sure that we're contextualizing care for a patient and their family. So this would be, for example, not providing medication that needs to be refrigerated if a person doesn't have utilities or they're shut off or they're not currently housed. So trying to think about ways to still provide them the best care possible, but within kind of their current social context. So the policy context, you're likely all aware as well about growing calls to screen for and address patient family social risk factors in the context of healthcare delivery. And this slide is just some of the organizations that have come out in support of this, likely not comprehensive anymore. There's also a growing number of new quality metrics around screening and intervention, including from CMS, the Joint Commission, and CQA. So this figure was actually developed by a colleague of mine, Matt Pentel at Pediatrics at UCSF, showing how these new measures overlap. And so CMS in the red, green, and purple circles has different quality reporting metrics just on screening for social risks that take effect in January of 2024. And I'll focus mostly on the inpatient quality reporting. So this is, again, inpatient, not primary care. But they are now requiring reporting for food, housing, transportation, and utilities. IPV is still on the list for now, but it's thought that that's likely going to be pulled out for various reasons we can talk about later if anyone's interested. And these screenings are expected, given CMS is starting in inpatients, expected that they're going to expand them in short order to outpatient care settings as well. NCQA has also come out with new HEDIS measures that are around screening for and actually also intervening on identified risks within 30 days after a positive screen. And they're focusing on food, housing, and transportation. And Joint Commission more broadly wants organizations to outline how they're going to be addressing patient social factors, but they haven't come down with specific domains or more specific guidelines at this point about how organizations need to do this. So all this to say that there's growing regulations and incentives to screen patients and families for social risks, which in many ways, as we'll talk about soon, have gotten ahead of some of the evidence and isn't necessarily accompanied by the resources to implement these programs well. So in thinking about social care, I always like to take a step back and try to ground us in kind of why we're doing this. And this is an adapted conceptual model put forth originally by Gruwich and colleagues that helps to demonstrate that we have on the far left patients and families who might be experiencing social needs. And in healthcare, we try to screen and identify them. And we can, as noted briefly earlier, try to assist them directly, and that's that assist side, and or use shared decision-making to try to better contextualize and adjust care to better fit patients' situations. And these interventions are then hypothesized or aimed at decreasing unmet needs, improving trust and relationships between patients, families, and clinical teams, improving receipt of preventative services, reducing competing demands, reducing healthcare team perceived futility as well. So thinking about also the health impact on the healthcare team. And then the hope is that these will then improve outcomes. So improve health status and wellness, improve health equity, improve patient family satisfaction with care, trust in care teams, and while also improving healthcare team satisfaction and be protective against moral injury and burnout. As I've alluded to, however, there is only emerging evidence that these things can come to fruition. And unfortunately, some research that the opposite can actually happen, usually related to barriers to social care intervention implementation and limited resources dedicated to social care. So if we don't have the resources to do all these things well, we're not going to necessarily achieve these positive outcomes. So in 2019, the National Academy of Science, Engineering, and Medicine put out a report on integrating social and medical care. And this report outlined the goal of integrating medical and social care and also outlined what's needed in terms of resources for this integration, including having an adequate workforce, developing infrastructure, including IT, digital infrastructure, and financing of this integration. And so in their report, the authors outlined 5 ways that social and medical care integration can be achieved, with a 6th one more recently added. And I'll now go through these. So we've talked about the awareness piece already. This is how we actually identify patient social risk factors and needs. This is more commonly being through standardized screening. So actually having a tool that a health system might use to ask all or a subsection of their population. And this is to identify patient social risk factors. Kind of thinking a little bit about some kind of ethical questions in this area. There have been questions raised about, could screening actually exacerbate perceived or actual discrimination for patients? Are some patients being screened at lower rates, for example, related to reasons why it might be more difficult to complete screening for them in terms of language, interpreter use, cultural differences, or patients' own comfort kind of disclosing this information related to racism, discrimination concerns. And then if interventions are then tied to screening positive, you could see that if a subsection is not being screened, it might actually worsen disparities. Sorry, having slide movement. And then the assistance piece we've also mentioned is that actual intervention on social risk factors. And again, if this is tied to awareness, the screening, then you could see there could be some potential pitfalls in terms of equity of screening and getting those in need assistance. And similarly, adjustment, this is where we're actually accommodating to social risks. And then there are questions around, well, could adjustment be actually used to rationalize providing poorer care for patients if we're going to tailor based on social context, or are all treatments equally efficacious? And a lot kind of the response is typically, well, if we're providing evidence-based care to patients that they can't actually get, then that's also not appropriate care. So this is where the importance of shared decision-making really comes in, and making sure that we're not using this to provide or justify using poorer care, but trying to make sure that the care we're providing is the best and most achievable, accessible for a patient. And then alignment, which we haven't talked about yet, is how health systems, healthcare organizations can actually align with existing resources between the community and the healthcare sector. And this is where a lot of pre-work is often needed before starting that, especially assistance piece. And then advocacy is where in the healthcare system has a role for trying to advocate for development of new resources and calling for new resources, both within healthcare, but also the community. And then lastly, abolition is the most recently added or proposed A, and trying to make sure that, as I've kind of talked about throughout, that we're really thinking about an equity lens across all of the A's when we're doing it, and the importance of reviewing how we're implementing and how it's impacting our patients and healthcare teams. So I put a little bit of a question mark at my best practices because, again, there's a lot of emerging evidence. And unfortunately, a lot of studies being done for many reasons are in different contexts and using different tools. And so it can be hard to kind of piece together best practices, but there's definitely some that are emerging. I'm going to focus primarily on the awareness and assistance piece because that's where most people are. And there's a lot to still learn in this area. And I think a lot that we can also take from the behavioral health world, where there's a lot of overlap between things like screening using a PHQ-2, PHQ-9, and some of the kind of brief interventions used in the behavioral health context that we're all in primary care very familiar with. And just want to note, in terms of this screening piece, the awareness, there is this tension between standardized screening, which is kind of the direction where policy and incentives are taking us. Also very useful in terms of the pop health level of understanding our population, having actually documented standardized screenings within our health system or health records, versus more of a relationship-centered conversational approaches. And there's also been a lot of kind of discussion around the role of asset-based screening. So even though we're screening maybe for food insecurity and someone can screen negative or screen for having high food security, it's not really the same as trying to ask about other assets or strengths of our patients and families. And so how, if and how should we be integrating those in our screening as well? And then there's been a lot of emerging work around patient-family acceptability, and overall there's been high documented acceptability. But there have been patients and families noting some concerns, especially in terms of how we're documenting and sharing this information. And in terms of kind of best practices, the importance of being clear about why we're doing this work, having an empathic approach, making sure patients and families are understanding, just like with anything we're doing in healthcare, the why and how it relates to their health, which for the most part in studies, patients and families already know, but it's good to acknowledge. And gets to the next bullet about the importance of building trust and also kind of trustworthiness with our patients, families, and communities, especially related to when we're doing this work that oftentimes the community is already also trying to do with this in the same line. And so in terms of the actually implementing screening, there's a number of growing resources coming out advising on how to integrate screening efforts, and a lot focuses on education, training of frontline staff, of clinicians, making sure we're getting their input and buy-in so that it is actually something that they want to and can and will do and have the resources to do. And as well as a lot of the work has kind of, a lot of research in this area is focused on primarily resident training programs. So there's definitely a need to do more in the kind of non-academic settings, but definitely important to try to integrate as much as possible with existing workflows, and highlighting kind of how this is ideally helping with patient care and helping with streamlining the care and access to care that people are receiving. And this gets me to my big point that there's a lot of research needed still in implementing, but from some early evidence, we keep seeing that community health workers seem to be key players in, given that they often have the lived experiences, they have the trust and community embeddedness, and gets at the point of the importance of having trained and dedicated trusted staff to work on social care activities. There's also definitely the financial point. They are oftentimes more affordable than other roles for doing this work, though ideally we're not all just driven by finances. And there has been some settings, which I'll get to in a little bit as well, showing that if community health workers, there's actually a return on investment in terms of being able to free up clinician time. So instead of having clinicians, whether it's social workers or physicians, advanced practice providers doing social care work, that they can take on those roles so that the other clinicians can do things that are more billable. And so, although never like to talk about the ROI, it's also super important in terms of integrating this and making it sustainable. And unfortunately, the community health worker roles are often grant funded, which is not always sustainable, but there are ways that organizations have been using Medicare dollars to actually pay for community health workers. And then in terms of the assistance piece, this very, very important from what we're seeing and what we just know naturally, the importance of collaborating with community-based organizations and making sure that we're not just coming into screening and referring without knowing what's going on in our communities and trying to stay up to date with that in terms of eligibility, what resources people have and capacity for additional referrals. Much of the kind of work around successive interventions has had a lot of issues in terms of patient follow-up. Many of that is just challenges of the study, but then a common drop-off point for people to actually get resources that they're not eligible to the resources that they were referred to. So making sure we know what those eligibility requirements are, what capacity is, how to connect people. I think there's more and more kind of questions around digital inclusion as well, because a lot of resources now and apps are being developed that require internet and/or digital health literacy. So making sure we're also providing resources and referrals in a way that patients can take advantage of them, and making sure that we're actually following up ideally with patients and families after we are providing with assistance. And again, importance of thinking about the sustainability of these activities on the workforce costs, payment models, and some working on the thoughts around risk stratification as well. And again, community health workers and also here social workers are common players and actually being the workforce to provide these linkages and assistance. So there are more and more electronic platforms like Find Help, formerly Bertha, or 211 information exchanges, and now POW that enable others to also do these referrals. And so just to kind of recap some of the things that I've mentioned thus far, the importance of training education before we're even trying to integrate and implement this in our practices, need to be responsive to healthcare setting resources, their needs. So thinking about like the healthcare themselves and barriers to screening, needs for partnership with the community, need to continuously also evaluate the social care programs to make sure that they are being implemented as intended and make adaptations as needed, which gets to the next bullet, the adaptability of implementation. So making sure we are making sure that we're kind of also contextualizing how we're doing this in different settings, and continued need to looking also for the evidence to support social care as a preventative service. And then kind of just recapping some of the things that we've talked about of unintended consequences. This is again where education training, not just of staff, but of providers is really important to make sure that, again, we are equitably implementing these and monitoring also those process metrics, assessing the impact on equity, also thinking more big picture about payment and delivery system reforms and regulating the use of data so that, again, we can protect this information for our patients and feel more comfortable with documenting it when appropriate. And so I'm going to end just spotlighting five clinical settings that are doing are doing this well. This is by no means inclusive, and just some organizations and health systems that I'm aware of that are doing this work. And I did solicit some input from some colleagues when preparing these slides, and have not directly partnered with many of these organizations I'll be listing, and I'm presenting them in no particular order. So San Isidro is a community health center in San Diego, and they have this innovative family resource center, FRC, that helps families with application assistance for food stamps, housing, gas, electrical bills, domestic violence referrals, legal assistance, and other supports. And they have social workers embedded in the FRC that can help identify and prioritize needs and connect to resources within the community. And it's actually, this center, resource center, is located within their health center, specifically in their maternal and child health center. And as I mentioned, they do everything from direct resource assistance, employment disability, case management, community outreach, and can also help connect people to kind of new patient appointments and assist with Medicaid and Medicare enrollment. And they provide both internal and external resources, and have connected with 211 San Diego Community Information Exchange support, which helps to facilitate these resources with some bi-directional communication and tracking of referrals. And of note, UC San Diego in general is also partnered with the 211 CIE, and again can help to improve how services are delivered in the San Diego region. And there are other kind of 211 CIEs elsewhere. And it actually has 132 partner organizations working to try to better connect health, social, and educational sectors. So interesting innovation there. And then the Dimmick Center is actually a community health center network in Boston, Massachusetts, and they are very focused on services integration. And so the whole structure of their organization is centered around integrating medical, social, and behavioral health care. And they too have on-site resources, including even early child education programs, so preschool type activities available at the center, and they're tracking outcomes related to their social care interventions. They do universal screening. They have warm handoffs in terms of their referrals. They have 9 community health workers that all do social care, and they again are doing this using a resource database and care management tracking. And so I haven't gone into a lot of detail about finances, but Dimmick Center had done some work with Siren where they actually went through some of their kind of financial approach to social care. And so they use a combination of volunteers, obviously not sustainable, private funding, including foundation grants, city public health grants, state Medicare funding, and institutional funding. And specifically, I've called out their use of the ACO funding to support social care. And they are one of the sites that have demonstrated that using community health workers actually enabled their social workers or therapists to do more actual clinical care and provide more billable hours. So there was an RO, or has been an ROI. And I mentioned the ACO, so I should note that Massachusetts Medicare ACO, which started in 2018, supports community health worker work. And so they also have quality metrics as part of the ACO for universal screening for social risks, delivery system reform, incentive payments, and flexible services that encourage enhanced community and health system relationships, specifically focused on food and housing. And then Community Health Center Incorporated is a community health center network in Connecticut, and they too focus on integrated care models of care delivery, if that's not a theme yet. And they provide integrated whole person care for medical, dental, behavioral health. They also have specific focuses on homeless focused resources and school-based health centers, which kind of are naturally geared towards and focused on social care and serve populations that have been socioeconomically marginalized. And this network of centers has a unique partnership with the Weitzman Institute for Research and Innovation, through which they've partnered on a lot of practice innovation, much focused on workforce development and expanding specialty care access. And they're able to actually share and compare data across their health centers, which is very useful from a population health setting. And they also do a lot of work around quality improvement training and have this best practice forum, and to try to promote kind of quality improvement training, and also have this National Training and Technical Assistance Cooperative Agreement with HRSA to provide free training to health centers on clinical workforce development, which is, again, workforce is such a key piece in social care and integration. And then City Block, many of you have likely heard about the buzz around City Block Health, which is a startup working in Indiana, Massachusetts, New York, North Carolina, Ohio, and Washington, D.C. And City Block contracts with payers to provide primary care, behavioral health care, and social services to their member patients with complex needs. And just to highlight one of their kind of innovations during the more height of the COVID-19 pandemic, they started a mobile integrated care program that included different consultation visits by video and phone, text messaging, and in-home care. And when trying to kind of launch this, they actually provided computer tablets directly to patients' homes, but they found that actually wasn't enough to improve connectivity or digital services, which gets at some of the complexities of digital inclusion. But they developed a further innovation where they actually developed an emergency medical technician or EMT teams to assist with telehealth technology in their patients' homes. And the EMT actually would help patients connect to the telehealth clinicians. The VA has actually also done a lot of work in terms of trying to use actually distribute tablets to their patients, especially in rural areas or Pacific Islands. And they've had a bit of success with this kind of the distribution of tablets. Some of the differences why that might have been successful versus at City Block, less so. Just the distribution of tablets might be related to differences in the population. And VA has a longer history, I would say, of integrated social care. And then lastly, the People's Community Clinic, I had the pleasure of working with in Austin, Texas, a few years back, and they have a whole social care team that's dedicated to evaluating, assisting with their social care activities. And they have a very long-standing collaborative medical legal partnership and provide assistance in terms of things like public benefits, housing, immigration. And during the pandemic, they actually partnered with a local tech company to actually distribute devices to facilitate remote schooling. So this was not for healthcare access, but they saw that their patients were needing to kind of up and switch to schooling from home. And so partnered with their community to actually provide that for their patients. And they've also tried to even kind of experiment with different ways to disrupt how screening for social risks and offers of assistance are being implemented. So again, during the pandemic, had trialed text message programs and not relying on people having smartphones, so pretty low tech, to reach more patients and families during the pandemic. With, I would say, some mixed success. They actually ultimately transitioned back to focusing on community health workers in clinics and finding ways to expand their community health worker presence within the clinic. And so to close, I want to just leave you with some existing resources on social care integration. You may have noticed that a lot of the clinics I just went through, I think all of them actually are community health centers, which has a very long history of doing this work, though many non-community health centers are beginning to do this work, and not to say that it's the only places that are doing it well by any means. But NAC, the National Association of Community Health Centers, APCHO, have developed their Prepare tool for screening, which is used a lot, especially in community health centers. This map actually shows kind of the uptake of the tool across the US. And they have a number of resources that are relevant also to the non-CHC center setting in terms of actually starting to and begin implementing and integrating screening. They even have like a whole spreadsheet they've developed where you can kind of have suggested kind of follow-up for doing repeat screens and checking in about kind of resource use, which is, we don't have a lot of published evidence on, but is a useful guide for settings starting this work. And then I'm also a personal fan of a resource that was put out by OCHIN and Kaiser Permanente with involvement of one of Siren's co-directors, Dr. Laura Gottlieb. And it does a really nice job of also kind of walking clinics through the process of starting screening referral efforts, and even has great resources on like PowerPoint slides to show your teams in terms of why you're doing this, and walking you through different worksheets on how you'd actually integrate this within your setting. So to recommend checking that out as well. And then if interested in learning more, Siren has a few different podcast series, and also I'll put in a big plug for the second link, which is to our evidence and resource library, which I like to kind of think of it as PubMed for social care. So it tries to consolidate each month new literature, and actually on our listserv each month, you can get an email that actually separates out new research across the A's, the awareness, assistance, adjustment, advocacy, and alignment. And the evidence library is a great way to search for kind of specific things in a kind of collated list. It's if you ever see something that's not there and should be, always definitely let us know. And I'm happy to take questions. Please feel free to email me at another time as well. Always happy to talk more about this. And thank you all so much for having me.
All right, wonderful. Thank you so much, Dr. De Marchis, for that, where there's a lot to discuss, even more here. And as we enter into our discussion period, again, please, our participants, feel free to put your questions in the Q&A tab. I know we've got one great one that's already come in. I'm just going to come back to that one in just a second. But I want to go back to just start by going back to some of the tensions in this work that you mentioned early in your discussion. I loved how you put it, sort of this tension between the standardized sort of measurement effort on the one hand, and then the relationship-based efforts on the other. And I'm curious just kind of what you're seeing in that regard, maybe particularly with some of these very innovative organizations that are working hard in this space. Since this is National Primary Care Week, one of the things that we have often talked about in primary care is the burden of measurement, the burden of quality metrics, which often fall primarily, certainly not exclusively, but primarily on primary care clinicians. And so how do you see organizations navigating that tension well when it comes to doing this work?
Yeah, I think it's still something that everyone is struggling with. And I would say that although I kind of propose them as two different approaches, I think they're not mutually exclusive. And one thing that I often try to reinforce is that, kind of similar to a PHQ-2, like screening for social risks is not diagnostic. Like even the PHQ-9, there might be other reasons why someone might have a high score. So similarly, if and when we are using standardized screening, it doesn't stop there. You wouldn't want to just be putting in a direct referral, one, because it might be something they've already tried and don't want to again. They might not have kind of that that focus on addressing that during their healthcare visit or with their healthcare team. They might not actually see that they have a need, even if they kind of screened positive for something. So you still need to have that follow-up conversation. I think sites that are doing it well, as I've kind of alluded to, are often actually using, this gets to the Q&A question too, using community health workers to be doing the screening, because they often can have the time to actually sit down with someone and kind of introduce why the screening is happening. This is in like the ideal setting where you have those resources to do it. There has not been enough work, I think, around like how we can actually frame screening in a way that someone might be able to like read through it on their own and self-complete it to understand why it's being done, and again have that kind of empathic approach, which in some of our prior research, people said like it doesn't necessarily need to be someone walking me through it or talking to me about it, but like you need to explain it. So I think there's more work we can do in terms of like how we actually introduce it. And yeah, so that I think that relationship is important, and that's why I think in some ways that many of the community health centers are a bit beyond some of our other practices, because they have been doing this work for decades, kind of since their inception. They've came out of this kind of community movement, but yes, the challenges around kind of financing and training. So I don't know if I got too distracted in in my ramblings. So let me know if I didn't fully answer that.
No, absolutely. And I think that's a great segue to the first question from our audience about community health workers in particular. This individual writes, how have you, or how have the Spotlight organizations navigated getting funding for those community health workers? So if it takes a team, how do we fund the team well? And particularly given that some of the community health worker movements around the country have been sort of more ad hoc or grant-based. There's no sort of national standard for community health worker education and training. And so the questioner asked, does the future of more robustly integrating community health workers involve creating a more consolidated federal, a consolidated professional body around the idea of the community health worker, the role of the community health worker?
Yeah, so I don't go into the finances as much, and it hasn't been, I will admit, focus a lot of my work, but I have learned much from some of my Siren colleagues and just in working with clinics directly. And it is definitely a patchwork approach. There are more and more innovative ways to use kind of Medicaid, Medicare dollars to fund social care. So many organizations are using that as a way to fund community health workers and the work that they're doing. But it's still often kind of reliant as well as on things like grants or other kind of internal mechanisms. And I mentioned the Dimick Center was able to actually show an ROI, so they could actually start funding them and kind of paying for themselves. In terms of the future around national standards, I think I would again have some initial kind of bristle response, even when we're just talking about national standards for screening. Is that potentially a slippery slope in becoming a barrier for people to be community health workers? I don't know. That was just my initial reaction in seeing that. It's not definitely a space that I unfortunately have focused a lot of my work, but there is actually also a new bill in Texas that allows for community health workers to be kind of care navigators, and does require some, I believe, training education as part of that. But as a way to, this is focused more on kind of prenatal care, of having CHWs and even doulas be able to be reimbursed for being their patients' care managers. The logistics of just a new bill haven't been fully outlined, but there is some kind of education training with that as well. But yeah, I think the idea of having standards, and insofar as they provide support for and can kind of assist community health workers with doing this work, because we also don't want to be taking advantage of our community members who might be trying to do this work, but getting additional resources and training, I definitely support and think it makes a lot of sense for that to be a direction, as long as it's not proposing or also increasing any barriers to doing it.
Yeah. And I mean, this next question is I think related to this question of professionalization. And I know you're also a big educator of students and residents. We have a whole group of students in an auditorium with us today. And one of them is asking about the role of the medical student and a lot of this. And so as we think about building the workforce over time, for whom this is what we do as clinicians, right? This is what part of the fabric of what it means to be a clinician is to do this kind of integrated medical and social care. What is the role of students and trainees in doing this work going forward, do you think?
Yeah, it's a great question. There have been some studies in different organizations that are using medical students kind of as in volunteer roles for staffing a help or resource desk, or doing kind of actually being the ones doing the screening. And I think with the CMS and patient quality reporting, I found that way before these, a lot of times when I was a medical student or working with medical students, that's oftentimes they have the time to take a more detailed H&P and actually bring that back to the team and provide more kind of context for people's admissions, which you can similarly do on outpatient setting as well. Though I will say, whenever I'm in clinic, I feel guilty trying to set times for students in terms of how much time they can spend with the patient, but just clinics are busy, and when you're trying to see 9 to 11 patients in a half day, as we all know, that is really challenging and really not sustainable, and also challenging for patients too. They may not necessarily want a 40-minute conversation for their social context, but I think there's and for example, at our own clinic, the medical students have been spearheading efforts to kind of help with integrating screening. So they're not actually the ones that are doing it, but they've been doing kind of some trainings with our staff and kind of helping to update resources and follow up with patients about like, well, how's the screening going? How can we make it better? Also with the clinicians and frontline staff, like how is the screening going? How can we make it better? That's been a really kind of helpful addition as well, and kind of leading some of the QI efforts. So I think there's many, many ways. Again, we want to ideally also be learning from medical students in terms of innovative ways that they think we should be doing this and adapting it. And it's a great place to integrate scholarly activities or QI work, and also have on the forefront of their minds when providing clinical care.
Yeah, absolutely. And another great question from our medical student contingent participating with us today. This asks about insurance schemes, and for example, Medicare for All. How would we foresee changes in addressing the social needs in the clinic setting with that kind of scheme? And I think this gets back to your really wonderful exploration of the question of resources. How do we create the background financing so that these processes through insurance schemes, whether that's Medicare for All one day or whether that's our current insurance providers, how do we make that possible and payment schemes?
Yeah, I think it'd be highly dependent on what it actually looked like, Medicare for All. But I mean, I think a lot of the things, especially that fall under adjustment, that if we did not have to be constantly fighting against, like getting people prescriptions that are affordable, using pharmacies that have different kind of payment schemes. So if that was not something that we necessarily had to navigate for our patients and could provide more equitable, accessible care through all of this, some of that adjustment might be less present, and also might free up resources for some of our patients to maybe lessen some of their social risks. This is being kind of idealizing things. But it could also help to streamline how we integrate social care, and it would be less challenging trying to figure out, well, who's eligible for what, how can we bill what, never try to get too political in talks, but I'm obviously very supportive of anything we can do to improve equity and access for our patients, and also improve the ability to provide care on the healthcare team side as well. So how can we kind of streamline things? Like, would we not need as many eligibility workers trying to navigate everything? And could those people actually be used for other roles to provide kind of integrated social care? So I don't know if that really gets at the question, but happy to talk more.
Yeah, and I think the other sort of side to that question is measuring outcomes from these interventions so that we go back. And when I think about organizations like City Block and similar sort of primary care, social care focused startups, which are, basically taking venture capital funding and trying to do this because they're in the investment world, it's remarkable. There's fairly wide recognition that this is a space of innovation that is going to bring us better outcomes. We have a lot of data, as you've well presented to us today, that when we do these things, good things happen. There's so much data about investing in primary and social care and outcomes at the population health level. So how do we make that more ubiquitous? Bring it out of the venture capital world alone and really invest in other parts of the healthcare system.
Yeah, I think as I do more systems level work as well, and not just research, but even in research, talking to like leadership as well within health organizations, I think sadly a lot of it comes down to ROI. Like, can we prove that this is actually improving preventable utilization, avoidable like hospitalizations? Is it decreasing costs, which in some ways, if we're able to address patient social needs and they are able to actually focus on their healthcare, we might actually increase like primary care services. And yeah, so not utilization doesn't always necessarily go down, and that's what some studies have done. And there's been really mixed evidence on the ROI. But I think, unfortunately, the way our health system is currently structured, that is a huge kind of, I don't want to just say incentive, but a huge place where we need to demonstrate success for it to be more kind of widely adopted. But I think just the fact that there are these new policy regulations, for better or worse, this is going to be something that people are adopting because people follow what CMS does. And yeah, I'm not enough of a finance expert to know exactly how we have to reshape this all, but yeah, I keep coming up against like, well, you need to demonstrate ROI. And so I think some of the organizations that have been able to successfully do that, which again, like is facilitated in the Massachusetts example by them having this big kind of Medicaid ACO plan. So I think I see the next question coming a line where
Yeah, can you
yeah.
speak a little bit to this question about, and the question for our audience is about the interface with Medicaid programs in particular, and noticing that in certain of these innovative models that Dr. Marcus has presented us with, that they tend to be in states with strong Medicaid programs. And so what is the interface with Medicaid in this space that you found?
Yeah, so I would say the most striking example for me was when I started doing more work in Texas, actually, which is obviously quite different than California. But there are many health systems that are doing a lot of really innovative work, but especially in like talking with clinicians there, I was just struck by how much more of the focus is on prescriptions, just because things are not accessible, and like they have different prescription programs, where I feel like in California, although I complain all the time about prior auths and getting people medications, they're just with expanded Medicaid, it's not as much of like the singular focus, whereas it's definitely in non-Medicaid expansion states seem to be. And yeah, so I think that people are still able to innovate and use Medicaid dollars even in non-expansion states, but there is much more kind of higher uninsured populations that, again, primarily community health centers are seeing. But they have been able to be innovative, and this new bill that, gosh, I'm going to probably remember it wrong, I think 1157 in Texas, like they were able to, in a non-expansion state, using some interesting language and partnerships, which I can get into offline with people if they're interested, but find support for like expanding Medicaid dollars for like prenatal social care integration. So there are things that can be done, but more barriers for sure in non-Medicaid expansion states.
Yeah. What what do you think about? I noticed, for example, I love that the movement to add abolition to those A's came and from a journal of ethics, and so one of the things about ethics is the question, who is responsible? So when you think about this in the context of a discussion about primary care, is the approach we should have, not only within our own institutions, but also as a country and indeed internationally, is the approach we should have that primary care is fundamentally responsible for this, or is this everyone is responsible for this? And you could see potentially, and I feel like, because we could see the positives and negatives to both sides. I think on the one hand, we want to say absolutely that this is everyone's responsibility. We are all in this space together to provide health, to optimize health. So everyone from our primary care clinicians to our medical subspecialists and our surgical subspecialists is naturally involved in that project. On the other hand, we're starting from a space where primary care is already underfunded and undersupported. And so if we're going to think about the social capital and the monetary capital that goes into this innovative work, some might argue, well, it should go to primary care, right? It should particularly go to primary care. So what are you seeing on this, and what are your thoughts on that particular issue?
Yeah. Well, I think there's even the like ethical questions about like, does it belong in healthcare in general, not
Yeah,
in
yeah,
addition to kind of specialty versus not. And I think it's really interesting that CMS has chosen to focus first on inpatient. And so kind of from systems level at UCSF Health, I mean, that involves kind of all departments in many ways. So we're kind of taking a like, well, this needs to be rolled out everywhere, also with the expectation it's going to move into outpatient and not necessarily just primary care, but not just being influenced by policy. I do think this is everyone because it affects everyone, also our specialty care. And in some ways, depending on the specialty, that can be where I have the most challenges getting people the care that they need, or even just getting people able to like to see a specialist because of cost concerns and just concerns about kind of other competing demands they have in their life, in terms of not being able to kind of follow up with a specialist. And then I'm left feeling very uncertain about my quality of care, trying to do a lot of complex care in primary care. So I think, yeah, and I think naturally there are many specialists who are doing this work, and there's even some groups, like I've worked closely with some of our orthopedic department trying to kind of do this work, because it's not just something that our clinicians in primary care are thinking about. And I think pooling resources is also really critical and important. But like, for example, we have one social worker for primary care at UCSF Health, which maybe I'm not supposed to say, but that to me is kind of devastating. And just like can we kind of better pool resources to make sure that because patients are being seen in different touch points, like how do we make sure that they're getting connected to resources? How do we make sure that we're trying to support them and contextualize their care so that they can achieve their health goals and wellness and improve outcomes? But I will say, like, I think it's also, we don't want to say that this is healthcare's, this is only like healthcare's role, because I mean, the community has
right.
been doing this way longer, and there are so many social services. And I think it's important for us to take a step back too, and like try to learn from the community and really partner with the community. So we're not trying to like lead and innovate and things that have been being done in the community for so long.
Yeah, so it's a both and, not
Yeah.
an either or, right? In medicine, we're good at either ors, and I think in this context, a both and being as inclusive and wide ranging as possible is critical. And this, our last question, we have time for one more,
Yeah.
is about another both and that oftentimes, as with some of your examples, these innovations are happening in the context of urban settings. But what about rural settings? And certainly we know that many rural communities are being left behind in all kinds of ways, not just in terms of the provision of healthcare services, but also in terms of the provision of social care. So what are you seeing in this space in rural communities?
Yeah, I would have to kind of think more for better specific examples, but and I'm going to forget names, but we had spoke with a group up in Alaska that's been doing a lot of innovative work. I think their main home base is still Anchorage, which depends on your perspective if you view that as rural or not, but have a network of CHCs throughout kind of Alaska that is doing a lot of innovative work and a lot of exciting partnership with the community. They don't actually, gosh, again, I'm going to kind of mess this up on the spot, but they don't even refer to their kind of patients as patients. It's more like community members, and they have a whole kind of tribal board and council that advises on all of these decisions. And so they've taken more of a strengths-based approach to screening and really focusing on like, well, how can we kind of lift up and take and help kind of promote the strengths of our community instead of kind of just focusing on like risks. So that is kind of one example. There's also some practice-based research networks in like rural Colorado that are been kind of trying to do a lot to implement screening for social risks. And I am happy to also talk offline if the person with that question wants to email me, and I'm happy to send additional kind of resources and support. But there is a lot of work in the rural context as well, even other contexts trying to use EMTs for kind of social care and social care delivery. So
Excellent.
yeah, challenging across the board.
Yeah. Thank you so much. This has been a really wonderful conversation. Really appreciate you taking the time, Dr. De Marchis, to guide us on this journey. It's a journey that we're all on. We're the both and no matter who we are and where we're working in this space, whether we're inside healthcare or outside healthcare, and whatever specialty we might be. If we're inside healthcare, this is our work. And so thank you for opening that space to us. Our next medical center hour is a special community-based event in light of our discussion today, where we're actually having the medical center out at the community. This is the evening of October 19th. On that date, we will welcome psychologist, counselor, and writer Dasha Kuiper, whose recent book, Travelers to Unimaginable Lands, Stories of Dementia, the Caregiver, and the Human Brain, has been named one of the best books so far of 2023 by multiple outlets. This special medical center hour will be held at the center at Belvedere, one of Charlottesville's great spaces for gatherings within our older adult community. You can sign up to attend in person at the center's website, or you can also plan to join by Zoom, and as a Zoom link will also be available. We hope you'll join us for that. It'll be a wide-ranging conversation on human connection and communication and caregiving. Thanks to all of you, and we will see you in a couple of weeks.